Hi again. So let's talk about moving this machine learning beyond simple cancer, non-cancer classification into something a bit more disease specific. So how we did this in our cohort was looking at the fungal infection, histoplasmosis, versus non-small cell lung cancer. So looking at a specific type of benign disease that has often troubled radiologists because of the characteristics of the tumors or the bulbous masses that it can create in CT, really looks very suspect for non-small cell lung cancer. So what this means is that the subject is usually given the opportunity or needs the opportunity to have an invasive surgery in order to determine if it is actually cancer and requires further follow-up, when in fact it is actually a histoplasmosis, which is a fungal infection, which can be cured quite easily with a course of antifungals and doesn't require that sort of invasive procedure in order to have the patient feel more at ease. So in order to do this, we looked at a small clinical cohort of 71 subjects that were matched based on their age, their sex, their smoking history, and their lung function characteristics. Again, we use the same sort of point and click graph cuts approach for nodule and perinodular identification, the special clustering form of graph cuts to provide that segmentation. We extracted out those quantitative features, the same ones as before, so intensity features, texture features, border features, and size and shape features. And then we did reduction and selection in order to determine what features are indicative of fungal infection, what features are differentiable then from non-small cell lung cancer. And we're going to provide the best assessment in these subjects in order to give us a clear risk assessment of either fungal or non-small cell lung cancer. We again trained a multitude of classifiers and determined that, again, a neural network ensemble, so a series of small neural networks, was best for classification. And it achieved a fairly high AUC rate, so an AUC rate of 0.89, which is best at 1, but worst at 0.5, which is no better than random chance. So we are able to pick up a signal in just a small number of subjects using leave one out cross-validation in order to determine what is indicative of fungal disease and what is indicative of lung cancer. And we did then a comparison, since this is such a challenging clinical problem, to human observers. And so we had four radiologists and pulmonologists who are experts for at least 5 to 10 years, look at each of these images blinded and tell us how likely they think it is to be histoplasmosis, how likely they think it is to be lung cancer. And then we looked at their AUC rates compared to the machine learning AUC rates. And we saw that the best performing reader only achieved an AUC ROC of 0.89. And where the true benefit of the AUC extended plus machine learning tool was in specificity. So that's in being able to determine which are actually true fungal infections compared to true or false fungal infections. And you can see that there's a lot of disagreement among readers. So the interclass correlation coefficient, which is a measure of how readers are aligned in their assessment, was very low. So it should be 1 in a perfect world, but it was 0.5. And the weighted Cohen kappa, which is another assessment of that sort of inner reader variability, was also around 0.5. So what this shows was there was a need. And when we looked at the average reader, there was a definite need in determining what was actually fungal infection versus what was actually lung cancer or falsely assumed fungal infection. And so this provided not only a security for our state of mind in that the machine learning is providing something that the reader just isn't able to pick up on, but actually we were able to have conversations with these radiologists and pulmonologists and get them more on board with being able to have this sort of tool that would provide an additional, I think it's fungal infection, or there's a likelihood that based off of these features, it's most likely to be fungal infection, that could provide a bit of clarity for them and a bit more of support for them to make either a decision that is in line with their original thoughts, or that could contradict their original thoughts and make them think a bit harder on what is the actual best path for this subject. Should we do the invasive surgery in order to assess if it's cancer, or should we start with a course of fungal infection, see if it goes away, and then do another screening and see if the tumor is still there and still as prominent as before. And so this is something that is very important in the application of machine learning and medical imaging, are those conversations with radiologists. So we can have all the best data in the world, we can build the best tools, but if it's not applicable and it's not understandable to a radiologist or a pulmonologist or some sort of medical professional who's ultimately going to use it, if it's not easy to understand and shows benefit for them, ultimately it's not a great tool because it's not going to be used. So this has allowed us to understand how it could be used, where it could fit into the pipeline. Would they be open to it? Is it in fact needed? Because if they're doing fine on their own or way better than the machine learning on their own, then throwing in that sort of extra assessment wouldn't help them at all. It would just create more confusion in the disease planning process. But moving beyond that sort of question of disease state and what can we learn from each of these based off of the features that we had pulled. I mentioned before, these weren't the only characteristics, texture and intensity, and border and shape and size. They were a selected few. So we looked a bit more at how this modular tool can be applied to different features, and specifically ones that are related to other diseases of the lungs. So we looked at the relationship of lung cancer and COPD, or chronic obstructive pulmonary disease. So there's a known association of subjects who have COPD tend to have lungs that are more inflamed over time, and that inflammation is thought to make them more susceptible to having lung cancer, irrespective of their smoking history, which we know the biggest prognostic assessment for lung cancer is smoking history. And so we assessed these using, again, a high resolution QCC cohort of 278 subjects, all who had some form of COPD, but only 71 who had a confirmed lung cancer, and 207 who either had no tumors or they had a tumor that ended up being benign upon further follow-up. And we extracted out a set of features that has been related directly to COPD. So different assessments from a proprietary software called Vita Apollo, which has these characteristics that have been shown to align really well with subjects with COPD, but they haven't been applied to subjects with COPD and the potential of lung cancer in the suspected lung tumor. We again did the reduction and the selection of the features of these specific features that were pulled by Vita Apollo, and did a training of different classifiers, finding that a neural network ensemble for classification was helpful, but it only achieved an AUC-ROC of 0.74, which is not perfect, but ultimately we wanted to look at what is the best case scenario in clinic right now. And so that would be a multivariable mathematical prediction model, or some sort of lasso statistical model of these features and of clinical features in order to determine what's the likelihood of that overlap, excuse me, of COPD and lung cancer. And through this, we were able to do clustering of those features using the K-meteoroids clustering. And so this shows that not only was that informative for selecting out and reducing the number of features that we're ultimately throwing into a classifier, but it can also show us interesting relations. So one no-duh relation here is the cessation time and age are related, which makes sense because people who are older have had more time to stop smoking. But things that are a bit less, I guess, interesting to see, or a bit more interesting to see rather, is that the different covariance of the lobe characteristics. So why is the lobe skewness histogram selected over the lobe mean intensity, even though they're still highly related and clustered together? And then there are the most interesting features, which are those that are not clustered to any other features at all. So such as the PI10 here and the gold stage, what are they telling us that the other features just can't? And are they carving out a subset of subjects that are, or a subset of that signal that is able to provide additional information that backs up then the diagnosis of COPD and lung cancer? But I've talked a lot about the lung. Can we move beyond the lung and beyond CT imaging? Of course we can. We have a modular tool developed. We have the machine learning backing it up that has been well-established pipeline. So we've applied it then to breast cancer, specifically to the segmentation and the diagnosis in mammography images for breast tumors. And breast tumors are a bit different than lung tumors. It's less invasive to take them out, but more women are screened for breast cancer than people are screened for lung cancer. And there's different issues that come across to the fact that you're using a 2D image in the mammography as opposed to a 3D image. So there is signal that's either being lost or being distorted based off of the fact that it's just a 2D image of the whole breast as opposed to a slice of the body itself. And so what we did is we broke apart the pipeline, selected the parts that worked for this case scenario. We utilized a publicly available data set. Imaging is one of those sections that there are a ton of images acquired, and there have been quite a few large publicly available data sets coalesced. This is one of them that includes over 1,000 subjects with breast tumors that have either been diagnosed as benign or malignant, and have the images already acquired with them. And here we have more of a 50-50 split, and that is based off of the fact that that's what the cohort has. And here we did, again, tumor and perinodular identification. This tumor and perinodular identification, the tumor was already actually segmented using the publicly available data set. They had those segmentations done by a radiologist. So that's a great thing about using public data, is often somebody's already done some of the work for you. We did the surrounding perinodular identification by region growing. So any tumor, any tissue that wasn't tumor was assumed to then be the surrounding breast tissue. We again did automated extraction of those quantitative imaging characteristics, so the intensity characteristics and texture ones that have been used in 2D instead of 3D. So they've been altered down into 2D for this case, and doing reduction and selection of what are informative of either breast cancer tumor or benign non-cancerous tumor. Again, doing a training of an ensemble of neural networks for classification. We found that we had a really great AUC ROC of about 0.97. And this led us to believe that this pipeline is more robust to just changing the disease state and the disease, the imaging modality. And so what we're able to do then, because we're using a publicly available data set, is compare it to other machine learning approaches. Since this data set has been used by others, including these 5 papers here, we're able to see how our tool is performing compared to theirs. And we saw that we're performing on par or better in AUC ROC, and that our tool was actually much more specific. So it was better at picking out the true benign tumors, the true non-cancerous tumors, than it was able to pick out sensitivity, which was an interesting thought. And it begs the question of what are we doing differently that is taking out that sensitivity signal or specificity signal as opposed to more of a sensitivity signal. But that's one of the benefits of using publicly available data sets, and I'll link a couple on the website Blackboard for you to take a look at. They're free to download, and often there have been a challenge associated with them. So there are these sort of publications that have come out where people have used the cohort in a certain way, and you can provide then more support for how yours shakes down compared to theirs. And in the next video, I'm going to chat with you a bit about what I've been doing now in pulmonary hypertension, and then following up with the last bit on what are the considerations in using medical imaging for machine learning. I'll see you next time. Bye.